So we are continuing our NEET question discussion series, previous year NEET questions. So next 5 questions will be on fluid and electrolyte balance and about endocrinology. Last year's NEET gave more focus to acid-base balance, fluid balance, around 3 to 4 questions came on hyponatremia alone and 2 to 3 questions came on acid-base balance alone. We already have another video discussed on ABG analysis. You can go through that also. So continuing with our questions, already told you, always read the last line. So what is the investigation of choice, which means some diagnosis has to be made, and what is the investigation of choice. A 26 years old male develops an increase in shoe size with large hands and coarse facial features. So I think the diagnosis is more or less clear here. This is acromegaly. So what is acromegaly? What is gigantism? Both are due to growth hormone excess. Whereas in acromegaly, the growth hormone excess occurs after the bone fusion. In gigantism, the increase in growth hormone occurs before the fusion of bones. So since gigantism, GH excess, growth hormone excess occurs before fusion of the bones, they'll be very tall. Whereas in acromegaly, since the growth hormone excess occurs after fusion of the joint, after fusion of the bones, they will not be tall, but they'll be broad. So everything will be broad, which means there will be broad face, a large jaw, there will be large hands. So that is what is given in this question also. Increase in shoe size, which means there's a large foot, there's a large hand, and coarse facial features. So this looks like acromegaly. What is the investigation of choice for acromegaly? That is, what is the investigation of choice when growth hormone is in excess? Remember, in endocrinology, there are only 2 possibilities. A hormone can be in excess, a hormone can be deficient. When do you say a hormone is in excess? It has to be high in times when the hormone is actually secreted low. When you say hormone is deficient, it is low, the hormone level is low, when it is actually supposed to be high. This is when you suspect hormone deficiency or hormone excess. How will you confirm hormone excess? When it cannot be suppressed. You know very well that there's a feedback mechanism in hormonal control. When that feedback cannot control a hormone excess, it is said to be high. Similarly, when do you say a hormone is actually deficient? When it cannot be stimulated. I know this has consumed much of our time, but why it is very important to know is, we'll just take an example of cortisol. Cortisol is a hormone. When it is in excess, the disease is Cushing syndrome. When cortisol is high, the disease is called as Cushing syndrome or Cushing's disease. When the hormone is deficient, the disease is called as Addison's disease. So when do you say it is actually high? Normally, cortisol follows a circadian rhythm. Cortisol being the stress hormone, it is high during the daytime and it is low during the midnight. So it is high during the daytime, that is around 8 a.m. and it is low during the night time around 11 to 2 p.m. We'll take it as 12, midnight 12. So to diagnose Cushing syndrome or to suspect Cushing syndrome, there should be cortisol excess when times it is deficient, which means midnight cortisol is the test used to suspect Cushing's disease. It is like a screening test. Similarly, to suspect Addison's disease, cortisol has to be low in times when it is high, which means 8 a.m. cortisol has to be low to suspect Addison's disease. Now, how will you confirm that? To say cortisol is excess in Cushing's disease, it has to be high when times it is low. That is, midnight cortisol is high, and it cannot be suppressed. It cannot be suppressed. So we have some suppression test called as overnight dexamethasone suppression test, low dose dexamethasone suppression test, high dose dexamethasone suppression test. We are not discussing the details, but giving dexamethasone or external steroids will not suppress this cortisol. So this is the confirmatory test. Right? Similarly, in Addison's disease, cortisol is low. It is low in times when it is actually supposed to be high. How will you confirm? It cannot be stimulated by a hormone. Cortisol is stimulated by a hormone called ACTH, adrenocorticotropic hormone, secreted by the pituitary. This ACTH will not stimulate cortisol in case of Addison's disease. So ACTH stimulation test is the test done to confirm Addison's disease. Likewise, for most hormones, there are suppression test and stimulation test. So here we are dealing with acromegaly, which is actually growth hormone excess. So to suspect excess, the hormone has to be high, right? Growth hormone has to be high, but usually growth hormone is not measured. Growth hormone in our body leads to increased secretion of another hormone called IGF, insulin-like growth factor. Remember this name, insulin-like growth factor. So IGF-1 is high in acromegaly. But to confirm that, or the gold standard or the investigation of choice has to be, there should be failed suppression of this growth hormone. There is a test called glucose tolerance test. So if you could remember, insulin is the only hormone which reduces glucose, or insulin is the only anabolic hormone. This you would have discussed in your biochemistry. The counter-regulatory hormones are many: growth hormone, cortisol, epinephrine, thyroxine. So all these glucagon. So all these counter-regulatory hormones are catabolic hormones. They act in the opposite. They are catabolic hormones, and they act to increase sugars, increase glucose. And by feedback, so growth hormone increases glucose. This glucose has to suppress growth hormone. So to say acromegaly or growth hormone excess, glucose should not suppress growth hormone. So how do you give glucose? By glucose tolerance test. So giving glucose should normally suppress growth hormone, but in case of growth hormone excess in acromegaly, giving glucose should not suppress growth hormone. So that is the basis of glucose tolerance test. So this is the actual confirmatory test, or the gold standard test, or the investigation of choice. So coming again to the question. So the question is a case of acromegaly. So what is the investigation of choice? IGF-1 levels. I told you growth hormone leads to increased production of IGF-1 from the liver. Of course, it will be elevated, but is this the investigation of choice? No. So read the question carefully. Definitely it could be a screening test, but it is not the investigation of choice. Next is failure to suppress growth hormone by oral glucose tolerance test. So this is what we discussed. Glucose has to normally suppress growth hormone by feedback inhibition, but in growth hormone excess, even this inhibition fails. So glucose fails to suppress growth hormone. This seems to be the right answer. Next one is failure to suppress IGF-1 by OGTT. Seems correct, but usually we do not do this test practically. We measure only growth hormone suppression by OGTT. And growth hormone levels, it's not clinically tested. So the answer in this case is failure to suppress growth hormone by oral glucose tolerance test. I know this question consumed so much of time because I told you about when do you suspect a hormone excess, when do you suspect a hormone deficiency, how do you confirm a hormone excess, how do you confirm a hormone deficiency, because the entire endocrinology is based on only this concept, right? Okay. Coming to question 7 of NEET previous year question discussion series. So to understand this question, we will read from the last line. A diagnosis of Addison's disease was made. What is the cause of hyperpigmentation in this condition? See, this is the reason why in NEET question paper, always you have to read the last line, because the question seems large, and during times of stress during the exam, if you read from the first line, you can definitely miss. So always to have a clear picture of what you are going to read from the question and what you are going to answer from the question, always read from the last line. Because in this question, there is no need to read the first 3 lines, because they are given clearly. A diagnosis of Addison's disease is made. What is the cause of hyperpigmentation in this condition? So I think in the last question we discussed, Addison's is actually cortisol deficiency. If you see the adrenal gland, it is of 2 parts. Adrenal cortex, and the inner part is the adrenal medulla. Adrenal cortex, remember the term GFR. Zona glomerulosa, zona fasciculata, zona reticularis. Zona glomerulosa secretes mineralocorticoids. The important mineralocorticoid is aldosterone. Aldosterone is a part of the renin-angiotensin-aldosterone system. We have zona fasciculata. It secretes glucocorticoids. The important glucocorticoid is cortisol. And we have zona reticularis. It secretes sex steroids. We have many among them. And every hormone is associated with a particular disease. Okay. And zona and the medulla of the adrenal cortex secretes epinephrine. Okay, adrenal medulla secretes epinephrine. So Addison's disease is actually problem with the entire adrenal gland, especially adrenal cortex. Okay. So for all hormones, there is a control from the pituitary, ACTH, adrenocorticotropic hormone. So this adrenocorticotropic hormone has to stimulate zona glomerulosa, fasciculata and reticularis. But the catch here is zona ACTH does not have much control over the zona glomerulosa, which means the mineralocorticoid system is not under the control of ACTH. Okay, it is not under the control of ACTH. It is controlled by the renin-angiotensin-aldosterone system. Whereas zona fasciculata and zona reticularis are controlled by ACTH. This is very important when you discuss the pathology in pediatrics about a few diseases like congenital adrenal hyperplasia. We are not discussing that here. So, like in last class we discussed, we have cortisol, aldosterone, sex steroids we are not discussing, and we have epinephrine. So cortisol excess leads to a disease called Cushing's disease. Cortisol deficiency is Addison's disease. Cortisol excess is Cushing's disease. Cortisol deficiency is Addison's disease. Similarly, aldosterone excess is called Conn syndrome. aldosterone deficiency is again Addison's. So the thing is, when adrenal gland is destroyed, obviously everything is going to be lost. But since the zona glomerulosa, zona fasciculata and zona reticularis are three different parts, the hypersecretion can come differently. And epinephrine excess, you know the disease, pheochromocytoma. Deficiency is right. Okay. So in Addison's, I told you it's a deficiency of cortisol, it's a deficiency of aldosterone. So when cortisol is low, feedback mechanism happens. So I told you ACTH is the one hormone which is secreted from the pituitary, which increases secretion of cortisol normally. So when cortisol becomes low in Addison's, this feedback loop gets stimulated and more ACTH is stimulated. So there is cortisol deficiency in Addison's and there is ACTH excess in Addison's. This adrenocorticotropic hormones breaks into few products. One product is POMC, pro-opiomelanocortin. Remember, melanin is something which gives color to the skin or black color to the skin. So ACTH gives black color to the skin. So that is actually the question. What is the cause of hyperpigmentation in Addison's disease? Is due to excess ACTH, which produces pro-opiomelanocortin, which gives us color to the skin. Okay, we'll read the question again so we can discuss few other points. A 40-year-old man with history of pulmonary tuberculosis 15 years back, who had completed anti-tubercular therapy, now presents with severe fatigue. On evaluation, he was found to have severe hyponatremia, 115 milliequivalents, and his random blood sugar was 57. Physician noted hyperpigmentation of skin. So you remember in Addison's, I told you we have two hormones which are deficient: glucocorticoid deficiency or cortisol deficiency, and the other one is aldosterone deficiency or mineralocorticoid deficiency. Glucocorticoid or cortisol is basically the stress hormone. Okay, so the symptoms of glucocorticoid deficiency mainly is fatigue, mental changes, emotional lability. Mineralocorticoid, if you remember basic physiology, the function of aldosterone or mineralocorticoid is to retain sodium and water in the body. And to excrete potassium. Okay, so when there is deficiency of mineralocorticoid, the body cannot preserve sodium, it cannot preserve water, so they will go for hypotension. The body cannot conserve sodium because ENaC channels are stimulated by aldosterone. When ENaC is not stimulated, sodium is not reabsorbed from the distal convoluted tubules of the kidney. So they go for hyponatremia. Potassium is excreted by aldosterone. When that is not there, there will be hyperkalemia. And another important function of cortisol, like in last question we discussed, the function of growth hormone, the counter-regulatory hormones. There are 5 counter-regulatory hormones. One among them is cortisol, is to increase glucose. So when there is glucocorticoid deficiency, there will be hypoglycemia. So see, in this question, we have a few keywords. There is fatigue, which is a symptom of glucocorticoid deficiency. There is hypoglycemia in this patient. That is a feature of glucocorticoid deficiency. There is hyponatremia, severe hyponatremia, which is a symptom of mineralocorticoid deficiency. So even if they didn't give the wording like Addison's disease, If a question has been framed like what's the diagnosis in this case, you can tell it is Addison's. Actually, I combined two questions and made it into a single question. There were two questions on Addison's. One was a diagnosis of Addison's and another one was the hormone responsible for hyperpigmentation. Two questions came in NEET 2025 from this one topic alone. And sodium, there are many questions there. Just one important point about hyponatremia. Only the normal value of sodium in our body is 136 to 146 milliequivalents per liter. When the sodium is less than 136 milliequivalents per liter, it is called hyponatremia. There are 3 questions on hyponatremia in NEET 2025. So we can take some time to discuss hyponatremia also. So it is classified as mild, moderate, severe, like 130 to 135 milliequivalents per liter in our body. We called it as mild hyponatremia. When the value is between maybe 120 to 130, it is moderate. The textbook references vary. Some books say it is 125. When it is less than 120, it is definitely severe hyponatremia. Severe hyponatremia is one indication for giving 3% saline or hypertonic saline. The normal saline which we commonly use in our ward is 0.9% saline, also called as normal saline. 3% saline is called hypertonic saline. We'll discuss about this in the next question. So in this case they have given the sodium was 15 milliequivalents per liter. So it is severe hyponatremia. A very important take home, there are 2 hormone deficiencies or 2 endocrine disorders which cause hyponatremia. One is hypothyroidism and the other one is Addison's disease. Okay, if any question comes with the clue hyponatremia and it's an endocrinology question, please remember 2 diseases, 2 hormonal diseases or 2 endocrine diseases which cause hyponatremia are hypothyroidism and Addison's disease. Thank you. Coming to question 8 of previous year NEET questions 2025. So this question we'll read from the last line. Which of the following is not used for initial management? So you have to find out the disease and think about what treatment is to be given and not to be given. Remember the question, what is not to be used? During stress, we often get confused with yes or no questions. Okay, please note the word which is not to be used here. A 21 years old male with known type 1 diabetes mellitus presents with blood glucose of 700 milligrams per deciliter. Sodium was 128 milliequivalents per liter. Chloride was 88 milliequivalents per liter. The patient was severely dehydrated. I think the diagnosis is more or less obvious. This looks like a diabetic ketoacidosis. So to say diabetic ketoacidosis, there should be 3 criteria. The name itself says diabetic ketoacidosis. So diabetes means sugar has to be high. The latest criteria is sugar has to be more than 250 milligrams per deciliter to say it is high. There should be ketosis, which means the blood ketone bodies are commonly used as acetone has to be high. How high? It is more than 3 milligrams per deciliter. It may not be important, but just remember the value if you are able to. Next is acidosis. DK is one cause of metabolic acidosis. What type of metabolic acidosis? It is high anion gap metabolic acidosis. Okay, in NEET 2025, some 3 questions had come on acid-base balance alone. Metabolic acidosis. When do you say acidosis? Bicarb is less than 22 milliequivalents per liter. Only and pH is less than 7.35. If this criteria is there, we tell it as metabolic acidosis. Metabolic acidosis may be high anion gap metabolic acidosis or normal anion gap metabolic acidosis. There are 4 causes of high anion gap metabolic acidosis. That's a mnemonic mud piles, but if you remember Hackman, first and the most important cause is diabetic ketoacidosis. Then we have lactic acidosis. That is, some components are getting accumulated in the blood. In DKA, acetone gets accumulated. In lactic acidosis, lactate gets accumulated. And in CKD or uremic acidosis, again few acids get accumulated in the body, and there are some poisons like methanol poison, ethylene glycol poisoning. These are some acids get added onto the body. And we have normal anion gap metabolic acidosis. Usually there is one disease, renal tubular acidosis. If you remember this one disease, it is enough. And the second one is diarrhea. Any cause of GI loss causes normal anion gap metabolic acidosis. Because GI secretion is basically bicarbonate. It is a base. When bicarbonate is lost, it leads to acidosis. What type of acidosis? Normal anion gap metabolic acidosis. Okay. If we have to go to the next step, how is anion gap calculated? It is sodium minus of chloride minus bicarbonate. That is measured cations minus measured anions. I am not discussing the entire basics, but if you are able to remember, it is well and good. The normal value is about 10 to 12. If it is more than 12, it is called high anion gap metabolic acidosis. So in DKA, to say acidosis, actually bicarbonate is less than 22, but definition say in DKA less than 18 is enough to make a diagnosis. Okay, so DKA is one condition causing high anion gap metabolic acidosis. So this patient is having sugar of 700. He is severely dehydrated. They didn't give any mention about the ketones or acidosis, but this probably has to be DKA because there are only 2 hyperglycemic emergencies. One is DKA, another one is HHS. The previous term of HHS was HONK, hyperosmotic non-ketotic coma. Now it is called as hyperglycemic hyperosmolar state. Hyperglycemic hyperosmolar state. The treatment is basically the same. When sugar is high, we are going to reduce sugars, we have to increase hydration. What is the basic difference is DKA is an absolute insulin deficiency. DKA is an absolute insulin deficiency. When insulin is totally absent from the body, there will be acid formation or acidosis. Acidosis is more dangerous than just a hyperglycemia. In HHS, there is insulin deficiency, but it is a relative insulin deficiency. Some amount of insulin is present, so the acid formation does not occur. Even if you don't remember this one, both are treated in the same way. So how will you treat DKA? Because the question is what you will not do in DKA, right? So remember this order. DKA is always treated by fluids, potassium and insulin. So fluids has to be rushed in DKA. We are not discussing the actual fluid management, the dose and all, but remember, if one question comes, what is the important treatment in DKA? It is fluids and fluids. It is not insulin, it is fluids. The second step is potassium. Why potassium? Because insulin is a hormone. Remember, there are 2 in insulin. On giving insulin, glucose reduces, potassium also reduces. These 2 substances enter into the cells. So we are giving insulin to reduce sugars in hyperglycemia or DKA. As a side effect, potassium also reduces. So before giving insulin, we have to give potassium. Now what fluid you are going to give? So fluids are of 2 types. Again, it is reasonable discussing fluids a little bit because 2 to 3 questions came on fluids also in the last 2025 NEET. We are colloids and crystalloids. Crystalloids are the common fluids which we see in our ward during our residency, like the NS normal saline, Ringer's lactate, 3% saline, isolate M, isolate P, isolate G, and 5% dextrose, DNS, dextrose with normal saline, half normal saline, dextrose with half normal saline. So all these are colloids, crystalloids. Colloids are example albumin and hemosil. Crystalloids are very, very important in medicine because they are commonly used. So even if you don't remember colloids, remember crystalloids. Crystalloids are the fluids which are to be given in DKA. Okay, we'll continue with the question. So which is not used for initial management? 0.9% saline. In the last question we discussed 0.9% saline is the commonest normal saline which we use in the ward. If you remember the value, it has 154 milliequivalents of sodium and it has 154 milliequivalents of chloride. Even though it is called normal saline, it is not normal because the normal sodium value in our blood is 136 to 146 milliequivalents per liter. The sodium value of normal saline is high. The normal chloride in our body is 96 to 106 milliequivalents per liter, whereas in normal saline it is 154 milliequivalents per liter. So it is very high than our bodily value, but it is still called normal saline. Okay. So normal saline is used. Ringer's lactate can also be used. Ringer's lactate is more physiological than normal saline because it has 130 milliequivalents of sodium. It has I think 100 milliequivalents of chloride, 4 milliequivalents of potassium, 1.5 milliequivalents of calcium, and 28 milliequivalents of lactate. Okay. So normal saline contained only sodium and chloride, whereas oral contains sodium, chloride, potassium, calcium and lactate. Remember, this lactate is not an acid. This lactate, when the liver is normal, it gets converted in our body to bicarbonate. So it is actually a basic solution. So oral is basically a basic solution or an alkaline solution. Please remember that. On the contrary, NS is an acidic solution. Okay, we'll erase this also. So oral and NS are the two commonest fluids used. Obviously, we cannot use dextrose containing fluids because sugars are already high. So 5% dextrose, DNS, they cannot be used. So NS and oral are the commonest solutions used for fluid management DKA. So first option is a correct option. It is used. 3% saline. 3% saline is actually 3 times. I think it contains around 560 milliequivalents per liter of sodium. It is not the initial fluid choice. Okay, in the last question we discussed 3% saline is used only in case of severe hyponatremia. In this case, sodium is only 128. It is just a mild to moderate hyponatremia which does not need 3% saline. Also, we have something called pseudo hyponatremia. Before labeling someone as hyponatremia, we have to rule out pseudo hyponatremia. When sugar is high, it dilutes the blood, so sodium will be falsely low. Similarly, before diagnosing hyperkalemia, we have to rule out pseudo hyperkalemia because when lab sample is kept for a longer time, it lyses and all the potassium within the cell comes out. So before diagnosing electrolyte imbalance, we always have to rule out the pseudo condition, pseudo hyponatremia and pseudo hyperkalemia. So this could very well be a pseudo hyponatremia. Even if it is a hyponatremia, it is not severe, so it does not need 3% saline. So this is not used. So the question is which is not used in initial management. So this seems to be a correct answer, but we'll read the other options also. Intravenous insulin, obviously it is used. we discussed, it is the third step in management, and potassium monitoring, it is the second step in management. So fluids, either oral or NS initially, then potassium supplementation and monitoring, and insulin and glucose control. 3% saline is not used, hence it is the answer in this case. Coming to question 9 of the previous year NEET question series. So we'll read from the last line. Which investigation will you perform now? So we had to find out the diagnosis from the first 3 lines, and we had to tell what's the investigation. Maybe it's the next investigation. They didn't mention investigation of choice, so we'll keep that in mind. A patient was brought with severe headache and seizures. The sodium on admission was 98 milliequivalents per liter. A correction was started with 3% saline, and after 24 hours of infusion, sodium is 110 milliequivalents per liter. The patient develops mutism, quadriparesis, and altered sensorium. So what is the diagnosis, and what will you do to confirm? So we'll read from the first line. Patient had come with headache and seizures. So something is causing seizures. The sodium on admission was 98 milliequivalents per liter. Time and again, sodium is very important in NEET. The normal sodium is 136 to 146 milliequivalents per liter. When it is less than 120 milliequivalents per liter, we call it as severe hyponatremia. This case is only 98 milliequivalents per liter, so it is a severe hyponatremia. Remember, for severe hyponatremia, we had to give 3% saline. Okay. So remember, we had discussed there are 2 endocrine disorders which cause hyponatremia. One is Addison's disease and another one is hypothyroidism. Of course, question is not on that, just for a revision. A correction was started with 3% saline, and after 24 hours of infusion, sodium is 110 milliequivalents per liter. Another very important practical point in sodium management is sodium correction should always be slow. Means the per day or 24-hour sodium correction should never exceed 6 to 8 milliequivalents per liter. It should never exceed 6 to 8 milliequivalents per liter, which means the patient's initial sodium was 98 milliequivalents per liter. After correcting sodium with 3% saline, the next day value actually has to be 104 to 106 milliequivalents per liter. Only 6 to 8 milliequivalents per liter of correction is allowed. But this patient, it had jumped up to 110 milliequivalents per liter. So remember, in chronic hyponatremia, to maintain osmolality, the brain cells would have adapted by generating multiple anions within it. So when the sodium is corrected rapidly, it leads to brain edema and pontine myelinolysis. So this is a very important clinical scenario in NEET. Central pontine myelinolysis. Or osmotic demyelination. Okay. So it's nothing but osmosis. So we have brain cells here, and we have the blood outside here. So blood has a sodium which is low, and osmosis is movement of the solvent from regions of low concentration to the regions of high concentration. So initial solvent movement will be from here to here. So to prevent this, the brain increases the production of anions within to maintain osmolality, so this osmotic shift stops. But when you correct sodium, again the osmotic shift changes, because now the brain cell is full of anions and it is osmotically loaded. When you correct sodium, the osmotic balance increases. So osmolality of the plasma increases more than that of the brain. So again, more fluid will enter here. Solvent moves from the regions of low concentration to that of high concentration. So the cell slice. Even if you don't remember the mechanism, due to osmosis, due to change in osmotic shift, due to rapid hyponatremia, the brain cells, especially the pontine cells, go for lysis. When pons goes for a problem, we have locked-in syndrome. So that is what is given in this case scenario. Patient develops quadriparesis, mutism, altered sensorium. So this is actually a locked-in syndrome. So because of the history of rapid correction of hyponatremia, this is probably osmotic demyelination. How will you confirm it? MRA brain seems a reasonable option because MRA brain can pick up pontine myelinolysis. There is a sign called trident sign in the MRA. This is the trident sign of MRA. Okay, see here. This is the pons. If you remember, this is the cerebellum. The part in front of the cerebellum is the pons. We have a trident-like sign here. Okay, this is the sign of osmotic demyelination. May come in image question. And LP for CSF biochemistry. Lumbar puncture is a very important investigation in meningoencephalitis, multiple sclerosis, and such diseases. It has no role in osmotic demyelination. In brainstem evoked potential. If you are not able to understand the option, please leave it off, because brainstem evoked potential is not common investigation we discuss. So we'll leave off the option. EEG is used for diagnosis of seizures. Electroencephalogram. So MRA brain seems the correct answer here. Coming to question 10 of previous year NEET question series 2025. So a patient in hospital was given IV fluids and he or she develops hyperchloremic metabolic acidosis. What fluid will cause this? So in one of our previous videos we were discussing ringer lactate. It has 130 milliequivalents of sodium, 109 milliequivalents of chloride, 4 milliequivalents of potassium, 1.5 milliequivalents of calcium, and 28 milliequivalents of lactate. This lactate is not an acid. When the liver is functioning normally, this lactate gets converted to bicarbonate, which is a base. So oral is a basic or an alkaline fluid. On the contrary, what happens with normal saline? So normal saline is actually 0.9% sodium chloride. It has 154 milliequivalents of sodium and 154 milliequivalents of chloride, which is not normal for the body. And what happens when you give such a large amount of chloride in the body? It leads to hyperchloremia, obviously. So if you are not able to decode this question just by the word hyperchloremia, maybe you can say the answer in this case is normal saline. We'll just discuss the mechanism. So chloride and bicarbonate both are anions. So when one anion like chloride increases in the body, obviously the body will try to balance the electrolytes by reducing bicarbonate. So what does bicarbonate do? Bicarbonate enters cells. So on giving more amount of sodium chloride, high amount of chloride, to maintain osmotic balance, the excess bicarbonate enters cells. So what happens in the blood? Bicarbonate reduces. When bicarbonate reduces, we call it as, bicarbonate is a base. So when base reduces, it leads to acidosis. So there is increased chloride. So it is called hyperchloremic acidosis, and this is a metabolic acidosis. When bicarb becomes low, we call it as metabolic acidosis. So the explanation is actually simple. So even if you are not able to understand, just remember normal saline has 154 milliequivalents of chloride. It leads to hyperchloremia. So NS is the answer. Okay. Last year's NEET was important because so many questions came on acid-base balance and so many questions came on fluids and electrolyte balance, since it is very important for practical basis. we'll just discuss some important crystallites. So we discussed about NS, we discussed about RL, and these two are the initial fluids of choice in practically any condition, especially diabetic ketoacidosis or hypotension. But one important distinguishing factor here is sodium Ringer's lactate is actually a basic solution. So it is preferred in conditions causing acidosis, whereas normal saline is basically an acidic solution. So it is preferred in conditions leading to alkalosis. One important clinical utility here is, we'll think of diarrhea. Intestinal fluid is rich in bicarbonate. So in diarrhea, more amount of bicarbonate is lost. When bicarbonate is lost, we call it as metabolic acidosis. Also, we discussed diarrhea is one condition causing normal anion gap metabolic acidosis. So in diarrhea, what is preferred? Since diarrhea causes normal anion gap metabolic acidosis, always a basic solution or an alkaline solution is preferred, so RL is preferred. So the initial fluid of choice in diarrhea is RL. Whereas we will discuss vomiting. Vomiting is a upper GI symptom, that is, fluid is lost from the stomach. Stomach, the main fluid is hydrochloric acid, that is, it has more amount of chloride. So in vomiting, what is lost? Chloride is lost. And what is also lost? H+, that is, acid is lost, proton is lost. When acid is lost from the body, it leads to metabolic alkalosis. So diarrhea causes normal anion gap metabolic acidosis, but vomiting causes loss of chloride and H+, so it causes hypochloremic metabolic alkalosis. So what is preferred here? Fluid which is actually acid. So NS is the best drug because it causes hyperchloremic metabolic acidosis, right? So in simple terms, in vomiting, H+ is lost, chloride is lost. Normal saline gives chloride, and when more amount of chloride is there, bicarbonate also enters the cell, so acid is regenerated, right? So these are the two common crystallites, and a few other one-liners. There is something called isolate G. G stands for glucose. So isolate G is a fluid which causes glucose, but actually isolate G is a gastric replacement solution. So anyone who has vomiting, it is better to give isolate G. So if you remember that isolate G is the gastric replacement fluid, obviously it has to contain more amount of chloride, right? So the highest amount of chloride is present in isolate G. Now coming to isolate M. M is called maintenance fluid. We already discussed NS, normal saline, contains only 154 milliequivalents of sodium and 154 milliequivalents of chloride, whereas Ringer lactate contains sodium, potassium, chloride, calcium and lactate. Isolate M is even more expansive because it also has phosphate, it also has magnesium, and it has the highest potassium content in any fluid, which is 20 milliequivalents. Okay, it has the highest potassium content, and it is the M stands for maintenance fluid. M also stands for magnesium, and M also stands for maintenance fluid. It is the preferred solution in diarrhea, or basically whenever a person is not taking any intake, isolate M is the preferred maintenance solution. I think highest potassium amount may be the one-liner, if at all, if it is asked. We have another fluid, isolate P. It is similar to isolate M. It is the pediatric maintenance solution. Coming to dextrose containing solution, we have 5% dextrose and 25% dextrose. These are called as hypotonic solutions. Because what happens is, when we give a dextrose containing fluid in the blood or plasma, the entire dextrose rapidly enters the surrounding cells. Okay, the glucose is entirely utilized by the surrounding cells. So what actually remains is plain water. So it actually dilutes the plasma. 5% dextrose or 25% dextrose, even though they are good drugs, good fluids for hypoglycemia management, when given in the blood, because the glucose enters into the cells, it actually leads to dilution or hypotonia. So these are called hypotonic solutions. Hypotonic solutions are not good for fluid, because when blood becomes hypotonic, what happens? Because of osmosis, the solvent leaves the plasma and enters the interstitial fluid. So it leads to reduced intravascular volume and hypotension. So giving dextrose containing solution, it is not good in hypotensive conditions. Even if it is not asked in NEET, it is very good for a practical approach. Never give 5% dextrose or 25% dextrose in a hypotension or in a shock. So since 5% dextrose has this complication, people combine 0.9% saline with 5% dextrose. It's called DNS. So it gives glucose as well as it prevents hypotonicity. Okay. So we discussed a few things about acid-base balance. We discussed few things about sodium, fluids and electrolytes, because these questions were commonly asked. Thank you.